like Ben shared, I'm a physicist in Ohio, and I also work with Radiating Hope. There's a lot of people that are working hard to kind of expand access to cancer care. And I think what Ben's been doing with Rayos is awesome, because education lasts a lifetime. You can have a piece of equipment and it can break and it can be gone. But once you learn something, you can it's a fire that you can actually share with others. So I'm going to keep moving. So these are the learning objectives of today. So we want you to understand HDR brachytherapy is a treatment modality, and that includes the process, so kind of the patient flow, the selection process of patients, like who's it's appropriate for, a little understanding of the clinical outcomes and the dangers, and then the infrastructure requirements. What do you need? So many of you already have a program. Some of you are developing a program. So those that are developing a new program, this is going to be most appropriate for. But even if you already have a program, maybe some insights into the flow. We'll talk about the staffing, the room requirements, treatment equipment, imaging requirements, and finances. And then we'll get into some of the physics, the basic principles in terms of the production of sources, the materials encapsulations, the dimensions, the principles of decay, and the subtleties of source strength and activity. So I'm going to start with a little history. I always like to put a face to some of the discoveries, and we have these individuals, but we know that even though maybe one person got credit or gets credit, there was a whole lot of stuff building up to it and a whole lot of contributions from unnamed people. But see, these are some of the people that get the limelight. Henry Becquerel, he discovered radioactivity, and it's funny because it was an accident. He was studying the phosphorescence of uranium glass. So uranium glass was known to glow. People would put it in their windows in the evening, and after the sun went down, it would have a nice faint green glow. And in studying that, the light emissions, he discovered radioactivity, which is this spontaneous emission of energy. Building off of his work were the Curies, Marie and Pierre Curie, who discovered radium. They extracted a radium from pitchblende. It was a really grueling process, and they were friends with Becquerel, and they exchanged information back and forth. And an interesting story is that Pierre had loaned Henry Becquerel a piece of radium, something that Marie and he had extracted. And Henry put it in his pocket, and he had it in his pocket for a day, and it gave him a burn. And that burn was the beginning of the thought, well, hey, maybe we could use this to treat tumors. So the Curies, they loaned a tube of radium to a physician friend of theirs, Henry Danlos. And there are different, again, I give you a couple names, but there are other people who are doing these things concurrently. And we're not quite sure who was the first one to use radium on a patient, but Henry Danlos was loaned a piece of radium from the Curies, and he used it to treat a superficial lesion. He laid it on top of a superficial tumor, and it cured it. Well, it cured it locally. So radium and the daughter radon were used throughout the early years up until the 1960s. When iridium was first introduced, and they were used by lots of different physicians for lots of different treatment sites. These are a couple of the different tubes that they were in. They would be loaded manually. Here's some older images of some breast cancer treatments. As you may know, brachy, the word has a Greek origin, and it means short. It's referring to the distance. When we talk about cobalt-60 treatments for external beam, they call it teletherapy because tele is distant. So short. Brachytherapy short, tele. So in the 1950s, the first artificial radioisotopes were introduced. And that was, we created nuclear reactors. And so then we had some activation products. We were able to activate cobalt from nickel, irradiating that with neutrons. It would absorb a neutron and become radioactive cobalt. And then we also had fission products from the uranium splitting. One of those was cesium-137, and they were able to extract that and purify it. And both of those turned out to be really important radionuclides for many years. In the 60s, Iridium 192, which was also an activation product. This was derived from stable iridium, which was bombarded with neutrons to create radioactive iridium 192. And that's been a really important radionuclide up until today, and it continues to be. Although we've come back around to realizing and maybe appreciating the simplicity of cobalt 60. And in the 1970s, for years, these things were loaded by hand. The needles were loaded by hand. In the 1970s, the remote afterloading was introduced. And these were where the source was on the end of a wire and the wire would be inserted remotely. So this reduced the practitioner's exposure. So this is much safer for everyone. So that's the history. That's some of the background. So let's get into some of the operational items. So the treatment process itself starts with the physician prescription. Then there's the applicator placement, imaging of the applicator position, and then the treatment planning optimization. So optimizing the load times, and then the treatment delivery, inserting the actual radioactive source into the applicator and delivering it. Ideally, all these things are conducted on the same day. As we know, some things are planned once and then treated several times through a course. But I'll get into this. The big thing is once you've got that applicator in there, you don't want to move the patient too much. So the process, again, it's the treatment planning is the clinical examination where the tumor is imaged, the physician, the determination what they want to do, and they place the source applicators. There's further imaging to ensure that the position is correct. And then they use those images to create a virtual patient and optimize the treatment plan in terms of the dwell times. And then treatment delivery. Once it's all been planned out, you start the afterloader and you actually perform the treatment. So the process, the patient selection process, these are the patients that are good candidates. So you want to localize cancer. If it's diffuse, that's not going to be appropriate for brachytherapy. So something that's bulky, relatively small tumor volume in terms of if it's too large, then you're not going to be able to cover it adequately with the radiation distribution. And what we found actually, it's interesting. We used to use just a tandem and ovoid, and what they've really discovered is that adding an extra needle or two, a couple of interstitial needles to address the bulky mass rather than just the conventional pear shape can really get good results. You want a patient with good performance status. They're going to have to be able to either tolerate anesthesia if it's done under anesthesia, or they're just going to have to be compliant in terms of remaining still. You don't want a patient who's going to be moving around a lot or maybe in a lot of pain, so it's difficult for them to remain stationary for a long time. Some of these treatments take an hour, not necessarily the treatment delivery, but the whole process. And that's a lot of time for a patient to be sitting around with an applicator. So you want them to have a good performance status and be compliant. And as we know, a lot of these are often treated in combination with external beam. Sometimes it's a brachytherapy boost after external beam radiation therapy or interleaved within the external beam. So the outcomes, the clinical outcomes, I'll start with the good. So brachytherapy can be highly conformal, give a high dose to the target and minimize dose to the adjacent normal tissues. Disease-free survival and overall survival are greatly improved with the combination of external beam and HDR. This has been shown. That's why it's such a big important piece for cervical cancer, especially. The outcomes are great. So now I'm going to get into the bad. There are some acute side effects, and these things can happen. Bruising, swelling, bleeding, urinary retention, transient increased bowel frequency, diarrhea. These are potential side effects. They don't happen to every patient, but these are things that would be part of an informed consent. And in a small number of people, brachytherapy may cause long-term side effects, and that's especially a danger if there's any kind of if there's a misadministration or if the applicator is not imaged properly or it's loaded improperly. And so those can include the urinary and digestive problems. And some of those bad things are related to the ugly. Brachytherapy is highly dependent on operator skill. So you want to practice. And if you can practice on a phantom, that's great. But applicator placement is kind of an art form. And there's some people that have the hands for it and some people that don't. So if you don't feel confident, if you're not comfortable, know that it can be dangerous. So it's always a big thing is brachytherapy is kind of an art form, and it's definitely a different treatment modalities than external beam, where you have a machine that's delivering this. This is highly dependent on the placement of the applicators in the hands of the physician. So HDR program infrastructure requirements. So I'll go over the staffing, the room requirements, treatment equipment, the imaging requirements, and the important one which is financing, not just upfront, but ongoing. And there are these great IEAE documents that are really helpful to consult. One of them about a general setting up radiotherapy program that includes external beam. And then there's this other report number 30, which is specific to implementing high dose rate brachytherapy. So the staffing, it's much more labor intense than external beam. There's a lot of teamwork involved, and there's a lot of players. So, and it requires the engagement of all these different individuals and these different team members. So good communication is essential. It's essential in all things, but even more so with HDR. HDR has a high potential for a severe complication if it's done improperly. So this is just an example of a treatment flow from TG59. It's important that you create your own process flow and in consultation with existing ones. And there are several that have been published at this point. A lot of people have done failure modes and effects analysis of these process flows. You know, it's well begun is half done. You want to, if you're starting a program, you really want to start on the right foot and have this outlined, have the responsibilities outlined, and the communication channels outlined. And if you already have a program, you would still benefit from doing a failure modes and effects analysis, looking at the weak points in your chain and understanding your flow and documenting it so that if someone else comes and takes the role of the nurse or a new therapist comes, that you have adequate documentation for onboarding. So the room requirements, you've got an applicator insertion room that could be the OR. It could be a sterile room, or it could actually be your treatment room. An imaging system, and we'll talk about different options later on. And then a planning room where you're going to have your computer system to actually.
Hello.
Yeah.
Yes. Hello.
Yes. Yeah. And if you have some questions, feel free to put them in the chat. I'm not seeing the chat, but other moderators are, and we will address any questions. And if it's really important that I stop and respond to a question, do that. I just clear your questions.
Okay.
So
I think you're good here, Peter. You can continue.
Okay, cool. So the proximity of this facilities, how close these rooms are to each other, can really influence the flow and efficiency of the treatment. And there's a great quote about, first we shape our buildings, and then our buildings shape us. And it's true. So when we're planning a facility, we plan where the rooms are, and then where those rooms are constrain the flow of our operation. So if you're first building a facility, thinking about where the rooms are placed is really important. If you're stuck with the facility, and I'm sure some of you that already have a facility have learned, well, I didn't have a choice of where I was going to put that room, and that really adds an extra 10 minutes to every procedure. So if you have the opportunity to build that flow, it's really worth the extra time and thought, because you want to minimize the movement of the patient. Once the patient has an applicator in them, any kind of movement could displace it. And then that could lead to some of those complications we talked about earlier. So the three major layout options for the application, imaging, and treatment. So one of them is where you've got the treatment room with shared use of existing operating or procedure rooms. So you're just sharing use of a room that's already used for another purpose. And then you've got a treatment room for applicator insertion and treatment delivery. So you essentially, maybe you take them into the CT room to get them a CT scan, or you take them into the sim room to get a fluoro scan, and then you take them back to the treatment delivery room where you put the applicators, and then you later insert the sources. The ideal one is where you have an integrated brachytherapy suite. And I respect and I understand the fact that this is an ideal. It's actually not that common in the States, but if you're building a facility from the ground up, this is what you want. And that's where you have your imaging and your afterloader in the same place, where you actually insert the applicator on the table, image the patient, and then deliver it all in one flow, because then there's going to be less of a chance for displacement. Now, I'm missing, well, yeah, actually I didn't highlight it back here on the second one. This table on the left, actually, it's a table I just like highlighting. What it is it's on like an air hockey table. So you can see the hose in the back by the CT. This lifts it so that it's really easy. It's a smooth transition to slide the patient from the insertion to the imaging table. But things like that, and I think people have built their own, things like this are really useful, especially when you've got that applicator in the patient. So
Peter, there's one question about the room requirements. Do you know what the approximate area of the integrated brachytherapy suite is?
That's a good question. I think that like a conventional CT simulation room is sufficient, but I do not have a value for like the room space. It's interesting. We just turned our afterloader room into a CT simulator room. So our treatment room that's shielded, well shielded for cobalt, is going to definitely be able to is going to be able to provide a CT, but you may have to, or is going to be able to hold a CT, but you may have to add conduits and power for it. I'm sorry, but I can get back to you on a room size.
Okay, thanks. Good question, Moses.
Yeah.
Okay, onto equipment. Okay,
so the big piece are the afterloaders. So there's the afterloaders, the applicators, dosimetry equipment, and your treatment planning system, and then imaging as well. So these are the ones that I'm familiar with, the three major manufacturers. There may be others that I'm not, and actually, if you're aware of another one or another type, I would love for you to share it in the chat so I can learn about the other options that are out there. The big ones: Elekta, Eckert and Ziegler, and Varian. And I know that there is another Eckert and Ziegler. There's the Saginova, but I think the big piece, besides all this stuff that you'll get when you get you can consult and have when comparing these, I think the biggest thing is the fact that the Flexitron and Eckert and Ziegler models can provide cobalt 60. So the rest of these are iridium afterloaders, but the Eckert and Ziegler and Elekta can be a cobalt afterloaders, and I think cobalt has a lot of advantages. Kind of a basic outline. This is obviously the microselectron. It's this is specific to one model, but the principles are essentially the same. So you've got your source wire, and you've got a dummy or a check wire. So it runs out the check wire first to ensure that the path is clear, and then it and over here we've kind of got an example with the source guide tubes, and then running to an applicator, which would be inserted in the patient. So the applicators are important. The imaging system that you have is really going to influence your selection. That not all are P or MR compatible. So depending on how you're imaging, whether it's ultrasound or MRI, you're going to want to make your applicator selection based on that. And you can see here You can get a lot of artifacts in CT if you don't have the right applicator, and you can also get some great visualization with MR that can be overlaid or fused with the right applicator. And then also it goes without saying, I think that the patient population in terms of what type of treatments you're going to provide, that's got a big role in the applicators that you purchase. And here we've got some in this upper right hand corner, you've got some surface applicators for skin cancers and superficial lesions, keloids. So the imaging requirements, it's I think requirement is an interesting word. We want to image the patients, but it's important to recognize that we've evolved over the years with our capability, but we can still deliver good treatments with different forms of imaging. So historically, planar radiography, X-rays like an AP and a lateral X-ray have been used for your placement and your dwell times, and we've gotten good results with that. What we found is that the more we do, the better we get. So CT simulators allow for 3D treatment planning and allow us to be a little bit more mindful in the confirmation of the dose, in some respects, actually be able to see a bulky tumor and be able to concentrate our dose to covering that tumor. And also have to see where the bladder is and the rectum, and be able to spare them appropriately while also ensuring that we're covering the tumor. It's a newer thing, and it's surprised me. Some of the participants in the past have actually been doing MR. MR is kind of it's an expensive modality. The prices are coming down on these units, and I over here I have a permanent magnet, a style MR, but this is the kind of the gold standard for soft tissue imaging, and really allows you to really fine tune your treatment. But I'd be remiss if I didn't also share about ultrasound. Ultrasound's been going on for a long time, and it's been a proven method. This is another one of those modalities in imaging, actually, that's very highly user dependent. It takes a skill, but if you have that skill, and if you've worked to develop that skill, ultrasound can be useful in visualizing the application insertion and making sure it's where you want it to be. So the
Peter,
finances.
we have some questions about imaging before we move on.
Yeah, no problem.
So one is it necessary, this is from Joel, is it necessary to have the patient imaged and treated on a flat treatment couch, like in EBRT?
That's a good question. So my experience is it's always been on a flat bed couch, but I don't think so. Someone could correct me, and I could be wrong. So I would not say that I'm not stating this with confidence, but thinking it through, the reason we do it on a flat bed is because it's reproducible, and it's how we treat the patients in external beam. But if you're going to image them and treat them in the same way, I think that it might not be such a stringent requirement. But I've always treated on a flat tabletop, so I really can't speak to it with confidence.
Yeah, I would imagine if you're doing the simulation on a flat table, then probably want to do the treatment on a flat table too.
Mm-hmm.
But if you're borrowing a diagnostic CT, next door in the radiology department, it has a curved couch, I'm not exactly sure.
Yeah. I mean, it would be something worth investigating. I would hope that maybe there might be some publications about that. I think there are some reasons that we do the flat tabletop in terms of reproducibility, in terms of setting the patient up. I don't know that it's as easy to place the patient in the same position in a curved tabletop as it is on a flat tabletop.
Mm-hmm. We have another question from, sorry if I mispronounced this, Ayojani. When do we use the C-arm machine?
Well, the C-arm, the C-arm can be used to take images, or to be able to take planar radiographs. So this is essentially a C-arm. You can capture an image, AP and lateral, and you can use that to plan tandem and ovoids through the conventional method with your point A and point B.
Okay, great. And I saw a hand raised, but it looks like the hand is down. So let's continue.
Okay, thank you. Great questions. And yeah, I'd love to know more about the curve tabletop if anybody can find some information about that. So the finances, this is an important one. It's a tough one, and I've seen this problem before where the money will be raised to develop something and to start something, but then there's a maybe not so much thought put into the ongoing costs. So this is where Cobalt 60 has some advantages. So with iridium, we know, and this table I have over here is from the United States, but it mentions a source exchange 4 times a year. So that's an expensive cost, and if you aren't budgeting for it, you're going to end up treating much longer, which is going to have an influence on the number of patients you can treat. And then there's some questions about the quality when you're delivering a treatment over a longer period of time. So ensuring that there's capital for ongoing expenses, source exchanges, service is really important. But if your organization is investing in you and supporting you to attend these courses, like right now, that's a good sign, because the biggest expense and the biggest most important element is the human resources, is people, and making sure that they're up on things. So these are the operational factors to consider: the radiation safety, the existing facilities, human resources, and the case mix, how many patients you're going to treat. Obviously, this table, is showing that the cervix would probably be the most frequent one, and that's the one that I think IEAE in general and others we're pushing it because we know that it's effective for cervical cancer. So key points to take away: the having awareness of your patient population, your staffing needs, what you have available, what's needed to start and maintain the program, the costs and benefits of the imaging technology, like what do you have, what might you need to invest in, and then remembering about the location, like how you set up your flow, how you set up your facilities is really important. So that was the more relaxed part. I think this is still going to be relaxed, but now we're going to get more into the technical aspects. So we're going to get more into the fundamental physics. And hopefully a lot of this is review, but hopefully also there's some new things too. So basics: radioactivity. We know that this is the release of energy, spontaneous emission of energy. There's the electromagnetic, and then there's alpha, beta particles, and each of these have different transmission properties. Alpha particles are stopped short, beta particles will go a little deeper, X-rays can go right through you, gamma rays even more so. And then units of activity: Becquerel is the SI unit of activity, 1 decay per second, and that replaced the non-standard Curie, which is still used to define activity, but which converts to 3.7. I put a conversion down there: 370 gigabecquerels equals 10 Curies, since that's the common source strength for an iridium source. So decay, again, this is this should be familiar: the time for the half-life, or for the half of the atoms to disintegrate, and it's related to the decay constant. And activity, it's a function of time, is solved through this familiar n equals n sub 0 e to the negative lambda t. So this is a very common equation just used to calculate decay, but it's important to review, and this is the decay chain showing where radium comes from and then where it goes. So the sources, the two main options: iridium 192, which is created through activation of stable iridium 191, and it releases a whole bunch of different energies. I didn't include the spectra, but the spectra is all over the place, and we essentially assign it a mean energy of 380 keV. Its half-life is 73.8 days. So that means a source exchange every 3 to 4 months is advised. I've worked in facilities where it's every 4 months, so that's 3 times a year. And then I've worked at places where it's every 3 months, so 4 times a year. And the cost constraints and the usage in terms of time, those are all things to look at. And I think I mentioned it earlier, we used to use cobalt 60, but really the more recent innovation is that Eckert and Ziegler were able to miniaturize a cobalt 60 source. And you can see in this graphic that the miniaturized cobalt 60 source is roughly the same dimensions as the Iridium 192 source. So they're essentially the same size, that grain of rice on the end of the guide wire. And it's cobalt 60 is also an activation product from stable cobalt. And I'm sorry, I think I mentioned earlier about nickel. I think that's in the decay process. But it releases 2 energies, 1.17 and 1.33 gamma rays, and we just give it a mean energy of 1.25. Its half-life is 5.25 years, and source exchange should be every about 5 years. It can be stretched to 6 years, or it could even be a little earlier. But these are important things to make sure that administration is bought into and preparing for, so that there's the capital for the source exchange at a regular interval. And I think that's been a reoccurring theme, is that the administration will buy an afterloader and buy a source, but then they'll be very slow to exchange it. And so whatever role you can play in driving that and ensuring that you get new sources is important. So characterizing the sources, there's the specific activity. So how much radioactivity per gram of material, and every radionuclide has a specific activity. Higher specific activity means the source can be made smaller. Iridium has a higher specific activity than cobalt 60. That's why it's traditionally been easier to make in small packages. So for a source of the same size, the cobalt 60 will have a lower activity. In that, Iridium 192 source will be about 10 curie, but a cobalt 60 source is about 2 curies. There's more to this. The air Kerma rate constant this is how you convert the activity into dose. So how you convert the number of emissions into the energy deposited in the material. So the cobalt 60 air Kerma rate constant is almost 3 times that of Iridium 192. So the same activity of cobalt 60 would have a dose rate 3 times higher than Iridium 192. So these two things in combination, the fact that Iridium 192 has an activity 5 times higher than cobalt 60 initially, but the air Kerma rate constant is 3 times lower, it means that the dose rate constant in air is approximately 1.2 times higher for Iridium than cobalt 60. So that means that the treatment times are going to be a little longer for cobalt 60, but you're still going to be able to deliver the equivalent doses. So recall that the SI unit for activity is the becquerel, and then the curie is still often used. Both of those are important for quantifying the material. Unfortunately, the problem is we can't really count those disintegrations and know the activity with certainty. So the activity can't be physically measured. We measure surrogates. So one of those is the source strength. So all sources arrive with a source certificate. These are results from measurements at the calibration laboratory that determine the strength of the source. And it's highlighted over here. You have the reference air Kerma rate when it was measured, and the estimated content activity. So they're using this air Kerma rate, and then they're converting it to activity. So the source strength was determined by the measurement of the air Kerma rate, and then that was converted to using a conversion factor to activity. And it's that use of the conversion factor that can introduce uncertainties. So what is the air Kerma rate? This is the recommendation. This is rather than converting it to activity, it's advised to just stick with that measurement value. So then you're comparing what you're measuring or what they measured to what you measured, not using that intermediate activity. So Kerma, the kinetic energy released per unit mass in terms of if you've got a volume, you've got photons or you've got energy coming in. If you've got photons coming in and then causing interactions, what is that energy that's been released in the unit volume? So the first interaction of ionizing radiation releases kinetic energy in a medium, and that's the Kerma. The second interactions result in the deposition through collisional Kerma or radiative Kerma, and that's where your dose comes in. But at brachytherapy, the Bremsstrahlung is essentially zero, so you don't have so much escaping that volume. So you can kind of use Kerma as a surrogate for dose. So air Kerma in practice. There are a few different versions of air Kerma that appear in brachytherapy source certificates, and it's important to recognize if you're being given air Kerma strength or reference air Kerma rate. And really the difference in these is the distance and the units. So this air Kerma strength is common in America, and it's using centigray per hour centimeter squared. And then it also sometimes microgray per hours per meter squared, or U. And it's important just to be aware of these different units and the subtleties. Outside of the States, who uses inches and miles because we're silly, our reference air Kerma rate. And that's the air Kerma rate at a reference distance of 1 meter from the source. I think this is a much easier term. It's much more straightforward. It's milligray per hour at 1 meter. So this is the ICRU recommended. And in Africa, I would presume that you would mostly be receiving your source certificates with reference air Kerma rate. But it's important to be aware that there are different ways of reporting this. So there are 4 principal factors influencing the dose distribution around a brachytherapy source. There's the distance, there's the self-attenuation within the source and the encapsulation, and then there's the attenuation in the surrounding medium, and then there's the buildup of scattered photons. So the inverse square, the distance, is by far the largest contributor to dose drop-off around the source. So those other items, buildup and self-attenuation, are important, but inverse square is an order of magnitude more important. So the inverse square, we're familiar with this principle, is where the intensity drops off at 4 times or squared the distance that you go. If you go from 1 meter to 2 meters, the intensity will drop off 4 times. And then 3 meters, it's 1/9. And this is just showing it's just based on the geometry. As the particles or the radiation spreads out isotropically, the area that they encompass, it gets larger and the number of photons diminishes. So the percent depth dose follows closely the inverse square law within the first few centimeters for radium-192. And this, you can see it almost overlays for the first 3 cm. And in brachytherapy, this is kind of what you're interested in. So inverse square almost approximates the dose deposition. With cobalt-60, it's a little different because the cobalt-60 emits higher energies in comparison to radium-192. It's a little different contributions from absorption and scatter effects. One of the cool things about cobalt-60 is that because it's higher energy, the source encapsulation effects don't matter to it so much. So whereas you have that butterfly with iridium, it's closer to an apple with cobalt-60. There's still some dimpling at the bottom with the wire, but there's no dimpling at the top with the source encapsulation. So those different energies also result in different radial dose functions. Although the inverse square is still the largest contributing factor, it's not quite the same as iridium-192. So reviewing what we've kind of talked about, wanted to go over HDR brachytherapy as a treatment modality, the treatment process, the patient selection process, the clinical outcomes, and infrastructure requirements. And then we wanted to review the basic principles of HDR sources: decay, source strength, dimensions, materials and encapsulation, and then the production.